Thank you, Rachel, for that very kind introduction, and thank you all for being here. I'm really happy to talk to you about some work that I've done on Medicaid expansion in Michigan. I would love it if you would all ask me questions as we go along. I realize that's sometimes hard to do, but if you want to just interrupt or raise your hand. I am better about answering questions as we go along and still keeping moving than I am at leaving time at the end. So if you have something you want to ask about, I encourage you to do that and not to be constrained by the fear that it's something that will be answered, because if it's something I'm about to say, I will tell you that. Okay, so please ask me questions. I'll try to make sure we have a few minutes at the end, but I'm pretty bad at that in general. So please don't be shy. Okay, so this is joint work that I did with 4 other people at the University of Michigan from both our health policy group and also from our macroeconomic modeling group. And you will see as I talk about it why we put that particular team together for this project. So I want to start by just giving a brief overview of everything I'm going to say, so that if you have to leave halfway through, or frankly, even if you have to leave in 5 minutes, this is the whole thing right here, really. So Medicaid expansion under the Affordable Care Act, which, as I'll talk about a little bit more in a minute, was a choice for states, presented a really complex decision for state policymakers who had to balance politics, economics, ethics, lots of different things. And focusing in particular on the economic arguments that people offered for Medicaid, for and against Medicaid expansion, people have made arguments all over the map about whether or not Medicaid expansion is fiscally good for a state or bad for a state. And when people have those arguments or discussions, I guess I should say debates, there's not even consensus on what outcomes you should be looking at. So there are all kinds of things people put forward as considerations to take into account in terms of whether Medicaid expansion is going to be good for a state's economy or not. In the state of Michigan, this question was particularly salient for us, and the reason we did this project was that the state expanded Medicaid in 2014, and I'll talk more about that decision, but the enabling legislation that made that happen included a provision that would require the program to shut down if the savings that the state realized from expanding Medicaid, and I'll talk more about what those are, were ever outweighed by what the state had to spend on the program. So the legislation basically said, this better not end up costing Michigan money or we're going to stop doing it. And so the question of, well, what is it doing for the state's economy was one that we became really focused on as the state had to start putting more money toward the expansion. So we approached this question. We found a tremendous amount of disagreement about even how you should go about answering that question in the field as a whole. And there was particular confusion about how you should think about economic spillovers throughout the state. So we're probably all familiar with these studies that say things like, let's build a new stadium, it'll bring a lot of money into the state. And then nobody really believes those studies because they think they're being done by the people who want to build the stadium. There's a certain component of that in some of these projections, and we wanted to make sure that to the extent that we were doing that kind of analysis, thinking about wider economic benefits in the state, we were doing it in as clear and straightforward a way as possible so that it wouldn't have this murky element. And I'm going to talk about how we did that for Michigan. We do find that the expansion of Medicaid in Michigan, we project that that's going to be a net positive for the state's budget, projecting 10 years into the future. And we find that the macroeconomic spillovers, and I'll talk more about what the other economic effects are as well, make up about a quarter of the positive impact on the state. Our analysis is, and I'll mention this multiple times as I walk through the rest of the talk, our analysis really is specific to Michigan. Every state has a different budget and tax system, and how expanding Medicaid affects your state fiscally really depends on what is already happening in your state in terms of taxes and spending. But I do think that what we hope is that the work that we've done lays out a framework for anyone else who wanted to do this kind of an analysis, sort of a transparent, nonpartisan analysis of what the fiscal impact of Medicaid expansion would be in their state. It gives people the tools that they need to do that kind of an analysis. All right, so that's where we're going. All right, so let me back up a little bit, and probably many of you know about this even better than I do, but just to get everybody on the same page, prior to the Affordable Care Act, which was enacted in 2010, essentially all low-income children were eligible for coverage through Medicaid or the state-specific program known as CHIP, which goes by different names in different states. Some of the parents of these low-income children were also eligible for Medicaid or CHIP. Who was left out of eligibility for public health insurance is childless, non-disabled adults. So if you were a childless, non-disabled adult, there were 7 states that had made it possible for that group of people to get Medicaid coverage up to 100% of the poverty level, which in 2010, I think was about $14,000 for a single person. That may actually be a family of 4, and if it is, I apologize. In any case, okay, thank you. So the point is that there was this big population of low-income people who, because they didn't have children and because they weren't disabled, they couldn't get access to Medicaid. That was the situation before the Affordable Care Act. Another important piece of background information is that the way the Medicaid program is financed is that the federal government matches the spending that the state puts in. So unlike Medicare, the program for people 65 and older, which is completely federal, Medicaid is run by the states and it's financed jointly by the states and the federal government. And the match rate that the state gets on its money depends on how wealthy the state is. So there's this actual formula which appears in the Federal Register that says, as a function of the state's per capita income relative to the average national per capita income, here's how much you're going to get from us. So in practice, the cents on the dollar that the federal government is paying for in the traditional Medicaid program varies from 50 cents to 84 cents. And so the 50 cents is in states like New York, New Jersey, Massachusetts that are very high income states. And the 84 cents, that's actually, in practice, the highest is 74 cents. The 74 cents is in states like Louisiana and Mississippi that have very low per capita income. So if you are a low-income state in your traditional Medicaid program, the federal government is putting in a lot more money than you are. This is before the Affordable Care Act. And on average, nationally, the federal government, prior to the Affordable Care Act, was paying about 55 cents of every dollar of the Medicaid program. Okay, one other piece of background I want to give you, and then we're going to talk about the Affordable Care Act. It's very important to understand how big a piece of state budgets the Medicaid program is. So as of 2010, when the Affordable Care Act was passed, Medicaid was, on average, the largest single item in state budgets. So here's a pie chart from the National Association of State Budget Officers, and you can see that Medicaid is almost a quarter of state budgets, 22.3%. And more than half of that money is coming from the federal government into the state. So the federal money flowing to Medicaid, even before the Affordable Care Act, was a lot of money coming into state budgets. All right, so that's the state of affairs from essentially 1965, when the Medicaid program was enacted, through 2010, when the Affordable Care Act passed. And when the Affordable Care Act was passed, it included a provision that would expand the Medicaid program, starting in 2014, up to everyone in families with incomes up to 138% of the federal poverty level. So you remember that I mentioned earlier that most of all of these low-income children were already eligible for Medicaid. Many of their parents were as well, and that meant that the people being made newly eligible for the Medicaid program were entirely adults, and most of them were childless. And in order to get the states to embrace this Medicaid expansion, because not all of the states were necessarily excited about expanding their Medicaid programs, particularly, as you may recall, 2010 was a difficult time fiscally for many states as they were recovering from the recession. States were not necessarily looking for ways to spend more money on things, and so the Affordable Care Act took a carrot and stick approach to getting states to go along with this Medicaid expansion. And the carrot was that the match rate, that is to say the amount the federal government was going to put in of the cost of this newly covered population, was 100% in 2014, 15, and 16. So if you expanded your Medicaid program to cover childless adults, the federal government would pick up all of the cost of that population for the first 3 years. And then the share that the federal government was going to pay was going to slowly ratchet down a little bit, and the state would have to start picking up first 5% and then ultimately 10% of the cost of this new expansion population. So the 90% the federal government share phasing down to 90%, and the states having to put in 10% is scheduled to take effect in 2020 and later. Okay? So the idea of the carrot is that basically it's free for 3 years, and then even after that, it's way more than the federal government gives you to cover the rest of your Medicaid population. So essentially, the deal they were making with the states is, we get that you're not crazy about covering these childless adults, but we're going to pay for most of it. Okay? So there's a lot of federal money. That's the carrot to try to get states to do this. Now the stick is that the Affordable Care Act also said, and if you don't do this, we're going to take away, we the federal government are going to take away all of the money we currently provide for your existing Medicaid program. Okay, so all of it. So that's the piece of the program that was covering millions of low-income children and their families. Okay, so that's a big stick. And that fact was not wasted on the states, and multiple states sued the Obama administration over the threat of losing existing Medicaid funds, arguing that this threat to take away all of the Medicaid funding for the existing Medicaid program, if they didn't change their programs in the way the Obama administration wanted them to, was coercive. And they also argued that the savings estimates that the administration put forward were unrealistic. The states essentially said, this isn't that good a deal for us, and we don't want to do it, and you can't make us do it. And in fact, that case went all the way to the Supreme Court, and you may remember the Supreme Court case that got a lot more attention was the one around the constitutionality of the individual mandate in the Affordable Care Act. Okay, so that one got all the press. This lawsuit that was bundled with it and decided by the Supreme Court at the same time was about whether or not the states could be forced to expand their Medicaid programs in this way. And it was and that got almost no attention leading up to the Supreme Court decision in late June 2012. But in fact, when the Supreme Court decision came down in June 2012, you may recall, they said the individual mandate is a tax. Of course, it's legal. So that ended up not being a particularly groundbreaking legal thing. But what was surprising to my constitutional law friends who pay attention to this was that the Supreme Court said you cannot coerce the states into expanding their Medicaid programs with this threat that you will take away all of their funding for their existing programs if they don't do that. So that effectively meant that in its effort to make a uniform eligibility standard, regardless of whether you were a child or a parent, in the effort to get a uniform income eligibility threshold across the country, which is what the Affordable Care Act was trying to do, instead what was going to happen was it was going to be up to the states to either embrace this program or not. Okay? Now the carrot remained. The carrot is the very generous federal financing for the program. And so each state had to make a decision. And that's why we find ourselves today having a table in the hallway outside, and I'll come back to this, with a ballot initiative. This was originally not supposed to be a state-by-state decision, but here we are. And so here we were in 2012 when this Supreme Court case came down, and suddenly governors and state legislators in every state found themselves facing a decision they had not thought they would have to make. Is our state going to expand Medicaid or not? So clearly, politics played a role in the decisions that different states made. So this is a map that I've borrowed from the Kaiser Family Foundation that shows you the current status of January 2018 of Medicaid expansion decisions. So the blue states are the ones that have not expanded their Medicaid programs under the provisions of the Affordable Care Act. The orange states are the ones that have. And so you can look at this map yourself and you can mentally compare it to whatever you have in your mind from election night on 2016 or something like that. But so you don't have to do too much of that. I'm going to show you a little bit of a breakdown. This is data that I took from someone else's published paper of how the Medicaid expansion decisions that states made based on political control of their governor's office and their state house. So what you see is that in the 15 states, and sorry, this paper is from 2015, and so the Medicaid expansion information here is the states that had made decisions to expand by then. So if you're looking at this and if you really follow this and you say, wait a minute, didn't Louisiana and Maine expand? Yes, they did, but they did after this paper was written. So that's why that's not maybe quite what you're expecting. But the point is, as of 2015, at the time that the initial Medicaid expansion decision was made, in the 15 states that had both a Democratic governor and a Democratic legislature, so we're in this square, all 15% of those states expanded, okay? And then in the 23 states that had a Republican governor and a Republican legislature, a quarter of them expanded, okay? So Michigan, which I'm going to be talking about, is in that quadrant. So we are one of the Republican-controlled states that expanded Medicaid anyway. And then you see in the places where there's split control, the governor's one thing and the legislature's a different thing, you get about 50% of them, a little bit more than 50% of them expanding. But for the most part, it's very clear that politics played an important role in what people were doing. And so the place that economics, I think, starts to get really important and interesting is when you're in this quadrant, right? Because if you're in a completely democratically controlled state, this lines up possibly with your policy preferences for having more generous social programs. And it also lines up with your desire to take money from the federal government to help fund those programs, right? It's not something you have to spend state general revenue on. If you're down in this quadrant, where it is not necessarily politically appealing to you to embrace an expansion of the welfare state that was put forward and enacted by the Obama administration, this is where you have to start thinking, okay, what actually is the economic deal that this program offers to me? Is this a good deal fiscally for my state, or is it not? And weighing those things against whatever your other preferences are. So that's what I'm going to be talking about. I'm going to be talking about this economic, this question of what is the economic deal that Medicaid expansion offers when you're in a situation where you actually have to think hard politically about whether or not you want to do this. And this question of what is the economic deal that Medicaid expansion offers, it started to become really, the rubber met the road beginning in 2017, because that's when the states actually had to start paying something out of their general revenues for the program. So in the first 3 years, the federal government paid the whole thing. So if you're the governor and you're putting together a budget to send to the legislature, you didn't have to include a line item saying we expanded Medicaid. But starting in fiscal 2017, you did. Okay, you had to start having a line item in your budget, 5% of the program's cost to pay for the cost of this childless adult Medicaid expansion population. And so economists started asking the question, well, if you only have to use state funds to pay for 5% of the cost, and the other 95% of the cost of the program is being paid by the federal government, surely all of those federal dollars coming into the state yield some economic benefit for the state. And surely some of that comes back to the state government in tax revenue. And so the question is, does that money coming into the state essentially pay for the 5% that the state has to pony up directly? Okay? And so that's the question people started asking. All right, and this is, I don't want to spend a lot of time on this, but there is a parallel debate going on at the national level over how we think about the economic impact of federal level changes that are scored by the Congressional Budget Office. But I'm not going to go into that in detail because it's just super wonky. Unless anyone here is actually from like the revenue estimating branch of the state legislature, please raise your hand if you are. Okay. Okay, so I won't go on about dynamic scoring. But okay, so what? Let me pause there. And I realize like it's hard to speak up in a crowd this big. But does anyone have any questions about what I said so far? Okay. So we started looking. So once we realized, okay, let's, we realized we needed to try to do something like this for Michigan, because this was actually, remember in Michigan, there's this thing in the law that says we're going to stop doing this if it starts costing us money. And we wanted to make sure that the people making that decision were really thinking through all the different economic benefits associated with the Medicaid expansion itself. And so we looked at the reports that people had written in other states, the analyses that people had done of other states' decision to do this. And there's a nice review paper by some people at the Urban Institute where they talked about different approaches that people took to this question. And it turned out there's just tremendous variation in how people interpreted this task. So if you work for some part of the state government or for an advocacy group in the state, and your boss says to you, I want you to write a report on the economic impact of Medicaid expansion in our state, the first thing you would have to do is figure out, what does that mean you want me to look at? Okay? And it turned out that people had interpreted that same task extremely broadly. So some people had focused specifically on the question that we knew we had to focus on, which was what does expanding Medicaid actually mean for your state budget? Like, what is the bottom line fiscally for the state? Some people didn't focus on that question. They just focused on more general questions like how many jobs will be created in the state, since that can also be an economic benefit associated with increases in federal spending in the state. And then in terms of methods, how people did this analysis, there were basically two different types of studies. One type of study said, if we expand Medicaid, we're going to save money on these programs that we currently spend money on, because we can say, those people won't be uninsured anymore, and to the extent that the state is spending money on programs to provide care for uninsured people, you have a lot less uninsured people, so you can save money on those programs. That's one kind of savings. But then whether or not they included the macroeconomic spillover effects on the rest of the state's economy and the increase in general tax revenue associated with those increases in activity was a big divide. And so we're particularly focused on this second piece of it. And that piece of it, the sort of is there macroeconomic feedback from the rest of the state's economy associated with expanding the Medicaid program, that's sort of also the murkiest question. Because as everybody knows, once economists start talking, once you put the word macroeconomic in front of something, it's going to be confusing. And that's just a fact of life. And that was true when we looked at this area also. And as a sad fact, most of these studies don't really explain their methods. There are limitations even on our ability to explain our methods because we have to use a proprietary model, which I'll get to in a minute. The bottom line from all of these existing studies being very different from each other, it's not like there's some standard format they were in or some standard set of outcomes they were looking at, is it's understandably really hard for state policymakers to figure out what to make of these studies. And you don't really know, do I believe these estimates, or is this the equivalent of the report saying that we should build a big stadium because it will make money, but it's actually funded by the Stadium Builders Association, right? And how do I evaluate these things? So we have a lot of sympathy for people who are state policymakers, legislators, their staffs who are trying to make these decisions and have to evaluate reports that may not do a great job of explaining their methods. And so we knew we wanted to do as clear a job as it is possible to do in explaining what we thought would happen economically in the state and to the state's budget if we expanded Medicaid. And we particularly wanted to try to be clear about how much of it is coming from this murky area of the rest of the macro economy in the state changing. Okay, so let me just review briefly. Ultimately we found when we were doing our literature review, before we did our own estimates, we found 14 different analyses, 13 different states that included what we call a dynamic component, which is this macroeconomic piece of it that we were particularly interested in estimating. Not all of these studies actually took their estimates and translated them back into what it meant for the state's budget, which we knew we had to do. So some of them, as I mentioned earlier, just put out an estimate of here's how many jobs are created, here's how many people would be covered, here's how many jobs would be created in the state. Job creation is good, end of story. We knew we couldn't stop with that. We had to keep going and say, and here's how much revenue it's going to give back to the state. Because we had to be able to say in the end whether or not the program was actually saving the state of Michigan money. In these existing studies that we looked at, we found that most of them projected that there would be net savings to the state, although some of them projected net costs to the state in the later years of the program. And the reason it's in the later years is because that's when the state has to start paying for 10% instead of 5%. So in the early years, there's no cost to the state. It's all paid for by the federal government.
So will it ever go above the 10%?
Great question, and you're like a Republican legislator over there. So that is exactly one of the things that people opposed to doing this have said is that, look, it's like a balloon. There's going to be the balloon payment, right? And then and also another piece of that is, and once you get people on these programs, it's very hard to get them off. So that was the argument that conservatives made to try to say, essentially this is a trap, and that's not crazy, right? And here's why it's not crazy. It's not crazy first because the second piece of that argument is hard to get people off these programs once you have them. That is true. So there are examples of states that have cut back Medicaid benefits, particularly in times when the state was having economic difficulties. They'll cut benefits for optional populations like previously childless adults. So it's not crazy to say that once a benefit becomes established, it's harder to take it away from people. It's also not crazy to think that the 10% might change, because if you stop thinking about the Affordable Care Act for a minute and you think about the debates that people have about entitlement reform, what is it that the people who want entitlement reform talk about? Well, they talk about things like making block grants to the states for their Medicaid expenses. That means that 10% is no longer 10%. Okay, that whole formula goes away under a block grant. And the whole point of the block grant is to be giving the states less money for their Medicaid programs. Did that make sense?
Yeah.
So it's not, go ahead.
Well, how come the people who apply for the assistance, isn't that driven by the poverty line? So if they started to make more money, then they would be able to pay for their health care themselves, or no?
Oh, yes. No, that's right. So once you're above a certain threshold, you don't qualify for these benefits. Okay. The question is, where are you going to set that threshold? So what the law is trying to do is make first and make and then ultimately encourage the states to set their thresholds higher.
So the threshold has been set.
The threshold historically in most states for childless, non-disabled adults was 0. You couldn't. You couldn't get access to Medicaid. And so the whole point of the Affordable Care Act change was to set the threshold around about $15,000 a year for a single person. So anyone up to that level would be able to get these benefits. But that's what became a state decision. You know, do you set that threshold there or not?
So do we have, as a state, can we up this threshold?
Well, that's what your colleague here is out here with the ballot initiative. So let me say more about that. Well, no, because that actually, it goes back to, go back to my 2x2 table, which I stole from somebody else. Actually, I can go back to this one. So the orange states here are the ones that said, okay, we're going to move that threshold and we're going to get all these people on our program. And the blue states are the ones that have said, no, we're not doing that. Okay, so including Utah, and that's why there is still this debate. And ballot initiatives, the most recent state to flip from saying, no, we're not going to do this, to yes, we are, is Maine, which enacted, which agreed to expand eligibility through a ballot initiative. The governor, who is a Republican, the legislature is democratically controlled in Maine. The Republican governor had vetoed legislative expansion of Medicaid 5 times, and then the citizens of Maine overwhelmingly passed a ballot initiative to implement Medicaid expansion to increase this threshold. The governor has not yet acted on it, and do you know what argument he's offering? See if you can guess what he's saying it will do to the state. It'll cost money. He says, we don't have that money. It's going to cost money, okay? So that's what this is about. This is about, will it actually cost money? All right, does that answer your questions? Okay. Sure. Okay. Yeah, so basically what we wanted to do was we wanted to, in Michigan, not have anyone, well, we wanted to give people accurate information about whether it was going to cost the state money or not to keep doing this. Okay? And we also wanted to set up a template for a state like Utah. You know, if you want to do your own version of this, we hope this is a recipe for doing that, so that if you pass your ballot initiative and then you have the governor and the legislature dragging their feet saying it's because of cost, you know, you want to have numbers. You want to have that table of numbers in front of you. Okay, so this is about putting together that table of numbers. Okay, this is just a review of the other state analyses where this had happened. And these are just pictures of these. This is what these reports look like. So, you know, an issue brief on expanding Medicaid in Ohio from the Ohio Health Policy Institute. They're sort of all over the map. And from some of them, you can sort of tell that the authors had a strong opinion about what the answer should be. So, for example, here's the title of this report: Texas should participate in Medicaid expansion. It hasn't. Then this is the paper that we published in the New England Journal of Medicine called Economic Effects of Medicaid Expansion in Michigan, talking about these estimates that this paper sort of has the summary of what I'm telling you about today. So there are a lot of these reports, and these are the kinds of, you know, this is the table of numbers that you want to have in front of you when you're having this debate about what it's actually going to do to your state to make Medicaid available to more people or not. Okay, so now I'm going to talk a little bit about Michigan. So Michigan, you know, it's so beautiful here. It's hard for me to say in good conscience, you should all come visit Michigan. But it is a beautiful state, and there are those who love it. And we have, at the time of the passage of Medicaid expansion, we had and still have a Republican governor, Rick Snyder, who subsequently has mainly been in the news because of the Flint water crisis. This was all before that, okay? I mean, it was going on in Flint, but when these debates over Medicaid expansion were happening, that news had not yet broken. And we also had and have a Republican-controlled legislature in Michigan. Prior to 2014, almost no non-disabled adults without dependents had any access to Medicaid in Michigan. So there was a very small program that covered, I believe, 57,000 people. This population of Michigan is 10 million. Covered a very small group of people using state funds for something that looked like Medicaid, but that was it. So if you were a childless adult without a disability and you were very low income and you couldn't afford your own health insurance, you were not going to be getting it from the state of Michigan, okay? Some parents in very low income families, and when I say very low income, I mean family income had to be less than about $5,000 a year. And remember, this is a family with children. If you had income at that low a level in Michigan, you could qualify for Medicaid. This is prior to the Affordable Care Act. And so in Michigan, expanding the Medicaid program to everyone, including childless adults, with income up to 138% of the poverty level, was going to be a big change from what the state's benefit structure had been up until that point. The governor became a big proponent of doing this. And he did that both because he believed it was the right thing to do for the low-income citizens of Michigan who needed access to medical care, because as one of my colleagues who works in this area put it, apropos of a discussion of the of Medicaid expansion and then the Flint water crisis, one of my colleagues said, yeah, he was a good guy before he was a bad guy. And I think that's an accurate description of what that dynamic has been. So Rick Snyder, our current outgoing governor, actually worked very hard to persuade the Republican legislature to go along with expanding Medicaid in Michigan. It was not obvious that it was going to happen, but it did. In September 2013, they did it through what's called a Section 1115 waiver, which I would imagine some of you are familiar with. So this has been true in almost every Republican-controlled state that has expanded Medicaid, has done it using one of these waivers. Now, what are these waivers? These waivers are things where the federal government has a set of requirements that it imposes on states in exchange for giving them those matching funds. Basically, the deal is, we'll give you funds to run your Medicaid program, but you have to run it the way that we say, okay? Now, these waivers allow states to request a waiver from those rules and say, we would like to get your federal matching dollars for Medicaid, but we would like to do things a little bit differently. May we please do it in the following way? And in Michigan and and also in Indiana and Ohio, the nature of the request for the waiver was, we want to require some of these people who are newly getting Medicaid benefits to pay a premium, a heavily subsidized premium, and pay some cost sharing, just a few dollars, for their medical care, which is not allowed in traditional Medicaid. Okay, so most Medicaid recipients don't have to pay any premium or cost sharing, but the governor was, and the Republican legislature was more interested in implementing a plan where beneficiaries would have skin in the game, where they would be paying something. And also, on top of that, they wanted to have healthy behavior incentives so that if you went to your primary care doctor, you had a wellness assessment, and then you participated in wellness activities like smoking cessation, you didn't have to pay the premium and the cost sharing. Okay? So it's actually very similar, and this was the idea, it's very similar to how employers often structure wellness plans. So we'll give you a break on your premium if you agree to behave in more healthy ways. So I think that doing these Medicaid expansions through waivers that make the structure of the program mimic what a private employer-sponsored plan might look like is appealing for a lot of reasons. It's appealing to people who think that that creates an incentive for people to behave in healthy ways that traditional Medicaid doesn't. It's also appealing politically because you can say legitimately, we are not just expanding Medicaid, we are doing this in an innovative and market-oriented way. And if you look at the rhetoric that the Republican governors who had to persuade Republican legislatures to go along with this used, it was almost all language like that. And also typically the plans have names that don't include the word Medicaid, and they do include the word healthy. So the Healthy Michigan Plan is our Medicaid expansion. The Healthy Indiana Plan is Indiana's, and I cannot remember the name of Ohio's, but I would put money on it that it's something like the Healthy Ohio Plan. So for all intents and purposes, though, it is Medicaid with these other things added on top of it that may or may not change people's behavior. And one thing about it being implemented through a waiver is that having a waiver from the federal government, one of the things that the federal government makes you do if you're a state that gets a waiver is you have to do an evaluation. If you want to do things differently from the standard way, we'll approve that, but you're going to have to tell us how doing it differently mattered. Okay, so that meant that the state had to hire an independent evaluator, and in the case of the Healthy Michigan Plan, that evaluator was us, the University of Michigan. So I am part of a large team at the University of Michigan that is doing the state-funded evaluation of the Healthy Michigan Plan. Here, I have these papers up here. These are all written by other members of the team. None of these is mine. But these are just some of the things that we have learned about medical care and Medicaid in Michigan since the program started. And some of these are directly related to what we've been paid by the state to do. And others of them are research projects that we've done independent of the state funding, because we're now interested in what's going on with the Healthy Michigan Plan. So the project I'm describing to you today falls into that second category. So the state did not pay us to evaluate the economic impact of the Healthy Michigan Plan. We got funding from a private foundation, the Commonwealth Fund, to do the study that I'm telling you about today. But we are also engaged in activities funded by the state to evaluate the expansion of Medicaid in Michigan. Okay, so now returning to our sort of central question, remember that I said the Healthy Michigan, the enabling legislation for this expansion of benefits included a provision that would shut the program down if it cost the state money. And so this got real as we sort of moved into 2016. And in 2017 was when the state would have to start paying 5% of the program's cost. So remember, 2014, 15, 16, it was free to the state. Federal government was paying the whole thing. But starting in 2017, the state has to actually pony up 5%. So we became increasingly focused on this question of, well, what is actually the economic deal that Medicaid expansion offers to the state? And so we decided we were going to do a report on this. And we decided we're going to focus on the state budget impact, and we decided we would include what we call these dynamic effects, these spillover effects from the rest of the state's macroeconomy, which is in some ways the hardest part of the whole thing. But also potentially, if you don't do that, you're leaving out a bunch of benefits. So it makes Medicaid expansion look worse if you ignore these economic spillover effects. So we really wanted to find out how big those were. And to do that, we teamed up. So the origin of these discussions was within our evaluation team. We're a bunch of people, health economists, health policy people, some physicians. We're really focused on that side of things. And we were discussing this. And we realized very early we didn't have the tools to do this macroeconomic spillover analysis. We needed macroeconomists. I am an economist. I am not a macroeconomist. Frankly, I didn't like that part of economics all that much. But what we do have at the University of Michigan is we have a group that has worked for decades with our state's government and other groups within the state to forecast what is going to happen to the state's economy in the coming year. And the reason they do that is to figure out how much tax revenue the state will get so that it can then make a budget that doesn't lead to a huge deficit, okay? So essentially, this is the group of economists who, when the state says we need to write a budget, how much should the total be? You need economists who are willing to say, we project this much economic activity in the state, which will return the following amount of revenue to the state as taxes. So those were the people we needed, because those were the skills we needed. The trade-off was that those people who do that thing every year, when we got in touch with them, they were like, this is a little bit of a joke. I would not say this to them. But they were like, wait, did you say Medicaid or Medicare? So they are brilliant at what they do. They didn't know anything about the health programs in the state. So very clearly, this was going to have to be a team effort. And that is in fact what it has been. Although like all team efforts, it had moments where it just did not seem like, you'd be having a conversation, you'd think you were using some word the same way, and then it was like, oh wait, what? You mean that when you say dynamic? No. So there was a lot of that. But anyway, we ultimately all got on the same page, and we from the beginning, we were on the same page that our goal was to do something that policymakers could actually read and look at and say, oh, look, this is what's going to do to our state's budget if we expand this program. I understand this now. I no longer feel like I'm being offered a bottle of snake oil. So that's what we wanted to do, and you can tell me at the end if you think we succeeded. All right, so what did we do? Well, we had a big leg up here, which was that the state of Michigan, like every state, has a legislative fiscal agency that produces estimates of what different programs are going to cost. And in our case, we were helped tremendously by the fact that this budget agency, the House Fiscal Agency, had already produced estimates of what the savings to the state budget were likely to be from expanding the federal Medicaid program. So I'm going to walk through those so you can see exactly what those are. And they had also thought a lot about the question of what types of Medicaid provider taxes would be affected by expansions in Medicaid. So we start with the House Fiscal Agency estimates, and I'm going to walk you through those because those are important. And in states where the fiscal agency hasn't produced something like that, you can do them yourself, but it's hard. But we in this paper have some suggestions about places you can get those numbers if you need them. And then the second piece of it, once you walk through sort of the immediate budget changes, is this dynamic piece. And the way to think about that is you're bringing more money into the state, you're going to have more state tax revenue. So the way to think about it is, for the macro piece of it, if the state expands Medicaid, there is going to be a big truck with $3.6 billion in it that drives from Washington, D.C. to Lansing, Michigan, okay? And the question is, and that's going to get put into the Medicaid program, and the question is, how much of that $3.6 billion comes back to the state in the form of tax revenue, okay? And the alternative is to not have the truck drive from Washington, okay? So that's that. Yeah, right. So that is the answer. You're ahead of me. The answer is that the truck with $3.6 billion is not one you want to turn away. Okay. So I'm going to talk about how we think through those different issues. All right. So this is just a table that puts together a bunch of different estimates. And I'm sorry it's so small. I realize it's unreadable, so I'm going to tell you this probably even in the front row. It's fairly unreadable, but certainly from the back. So I'm going to tell you what this is. What we've done here is we've pulled together a bunch of different estimates that our House Fiscal Agency produced to help legislators make a decision about Medicaid expansion in the first place. And what they did was, the thing you have to start with, actually, is figuring out how many people are going to sign up for the program. And you can do that by estimating how many very low income, under 138% of the federal poverty level, people there are in your state who don't have insurance, and what fraction of them are likely to sign up if you have a program like this. And so the state, the House Fiscal Agency did that, and they said, well, you know, we think in the first year there's only going to be about 230,000 people, but then you're going to get more and more people, and we project that there's going to be about 600,000 people ultimately in this program. And remember, with a state population of 10 million, which is nice because it makes it easy, it's a nice denominator, it means this is about 6% of the state's population. And this projection, this was a projection, the 600,000, these first two numbers, which are detailed, this report was written in 2015, so they actually had accurate information on what had happened in those years. The 600,000 number for the projection for enrollment actually has been quite accurate. So we now have data for 2016 and 2017, and it's been a little bit higher than 600,000. It's been about between 620 and 680,000, but that is actually about the steady state number of people who have signed up, which is a lot of people. So and just to put it in perspective, compared to the rest of the state's Medicaid program, remember we had a Medicaid program before expansion that consisted of very low income children and some of their parents. There were about 1.9 million people enrolled prior to Medicaid expansion. So after Medicaid expansion, we increased the size of the state's total Medicaid program by almost a third. Okay? So there was a lot of demand out there. Yeah, question over there.
Just one small question. You said 6% of the overall population, but what percentage it is of the eligible?
Yeah. Yeah, that's a very good question, and I don't have an answer for you, which I should. It's not 100%, because remember, some very low-income people do get employer-sponsored health insurance, right? So some other people do have coverage. Yeah.
Now there are two aspects to it. One is, without any extra effort to publicize the program, how many would come who are eligible, and then later years when the program is known, because that rate will go up.
Yes. No, that's exactly right. And so that's partially why we see this, you know, the program essentially doubled in the first 2 years. So it started out around 300,000. The next year it was 500. The next year it was 600. In terms of the advertising, there's an interesting anecdote. So when this program started, my kids brought home in their backpacks from school flyers that said, does your family need health insurance? You know, these went home, I think they did county level outreach because the stamp was from our county level organization, but there was outreach, you know, letting people know, you know, you can now sign up for Medicaid in Michigan, which you couldn't before. I still have one of those flyers on the wall of my office. About a year ago, maybe 2 years ago, the state legislature actually reduced the Department of Health and Human Services advertising budget once it became clear, once they sort of realized that they were advertising to get people onto Medicaid. And the state legislator said, what are you doing? Why are you encouraging people to sign up for a welfare program? So whether you think this is a good thing or a bad thing really depends on what your philosophy is about the role of the Medicaid program in our safety net. Okay, so all right, so what we see is, so we get a lot of people, and up here at the top, they cost a lot of money. This is the total cost of the program, which is something in fiscal 2021, about $3.8 billion. And I focus on 2021 because that's when Michigan is paying 10%. Okay, that's the steady state share that the state has to be paying, that if you're a very fiscally conscious legislator, you're going to be like, well, fine, it's free now, but what about once we're paying 10%? So once the state is paying 10%, the state has to pay just under, the state has to pay just under $400 million for the program. So then the immediate question you have to ask is, okay, well, what else could we cut? So for example, the state was previously spending a lot of money on mental health programs for uninsured people. A lot of those people gained Medicaid coverage as a result of the expansion. So the state, now, and I don't want to suggest that this was without political arguments, but the state has reduced its mental health budget, that is to say what the state pays for it, okay, approximately in half. So you save money because the providers are now getting reimbursed by the federal government because the people they're seeing are covered by Medicaid instead of being uninsured. So our House Fiscal Agency estimated that savings alone was going to save the state about $168 million a year. Okay? They also, remember I mentioned that there was this program that covered something like maybe just under 60,000 people for limited health insurance, adults who didn't have access to Medicaid, who had health insurance that was paid for by the state. All of those people became eligible for Medicaid, and so the states didn't have to spend money on that program anymore. So that netted another $47 million, nets another $47 million a year. And then correctional health care. So people in prison, when they get their health care in the prison health care system, that's paid for by the state. But if they receive health care outside of the prison system, for example, you have someone taken from a correctional facility to the University of Michigan Hospital for a procedure, that person is now eligible for Medicaid. And the University of Michigan gets paid for that procedure by Medicaid rather than by the state corrections budget. So that's another big savings for the state. And then there's this other line is actually, it was a state-funded contraceptive program that people who didn't qualify for Medicaid could access free contraception through this program the state paid for. It was called Plan First. And then all of the people who were eligible for that program became eligible for Medicaid under the expansion, so the state ended Plan First. And that saves another $1 million. So you add those things up, these are savings that show up in the state budget, and for Michigan, that's estimated at $235 million per year. So that's part of it, right? But that's not all of it. So that's still less than the cost to the state of expanding Medicaid. But wait, because there's more. So the next thing we're going to look at is increases in what are called provider taxes. Now, every state has these. And how do they work? Well, here's the way they work. These are taxes on healthcare providers. And the state collects the money, and it uses it to fund its Medicaid program. Now, think about how these work for a second. The state decides how much healthcare providers are reimbursed when they see Medicaid patients. Okay, so one thing you can do if you're a state is you can say, providers, we're going to tax you, but we're going to raise your reimbursement. And when you do that, remember the federal government matches the money you put in. So you just increased the amount of federal money coming in for your Medicaid program. That's why all states have these, okay? They are a great way to fund your Medicaid program, even though they are politically precarious, because they require the provider groups and the legislatures to come to some kind of an agreement about what is a reasonable level of taxation and what is a reasonable level of reimbursement for seeing Medicaid patients. But the mechanical effect is if you have a big increase, if you have taxes in place on Medicaid transactions, on healthcare transactions, and you expand by 1/3, in the case of Michigan, the number of people with Medicaid, those taxes are going to bring a lot more money in than they were. Even if you don't change the tax rates, there's just a lot more healthcare money going through the system, and so those taxes raise more money. And that turns out to be about $177 million in the out years. And if you add those two numbers together, the $177 million from the taxes and the $235 in savings, it's just over the $399 million. So you can make an argument that just based on these things alone, you can pay for the program. But we didn't want to stop there. So what we wanted to do was we wanted to say, okay, what about the rest of the effect on the state? Like in Ann Arbor, we have a sandwich place right next to the hospital. And I have to believe that if the number of patients going to the hospital increases, the sandwich shop next to the hospital is going to do better, right? And we don't want to leave those benefits out. Now, the tricky part of it is it's really hard to know how much better they're going to do because of that additional money. And it's not just the sandwich shop, it's also the doctors are going to get some more revenue, and maybe they add a deck on their house, right? So you think about all of these spillover effects, but you want to do it in a way that's careful. You don't want to pretend that the money endlessly ripples through the economy, right? Like that's where you get the reports that nobody believes. So what we did was and this is essentially the only way one can do this, we contracted with a group called REMI, Regional Economic Modeling Incorporated, which this is what they do. They estimate these effects. And so, sorry, these are just pictures of the websites of REMI down here and the two other organizations that do this. This is the business that they are in, is figuring out how big these spillover effects are. And so what we had to do is we had to tell them, here's how much money is coming into the state. Here's how it's paid for, because we did have to take into account things like the fact that if the federal government is going to be giving us this billions of dollars, residents of the state of Michigan are going to pay slightly higher federal taxes. Now, we're not going to pay for most of that. The entire country finances the federal budget, right? And so we're not going to pay disproportionately more of that if we expand Medicaid, but we are going to pay for a little bit of it, 2.4% of it nationally. And so we specify all those things, and then you say, here's how much more economic activity in general comes into the state because of this. And so when we do that, this is important. We also have to figure out how much of that new spending stays in the healthcare sector. Okay, so to the extent that all we did was cut money out of the state's healthcare budget, that money doesn't affect what's happening in the healthcare, and some of it goes outside the healthcare sector. Okay, and then there's also going to be things like the sandwich shop and the contractor and all that stuff. So we figure out how many of those. I'm going to skip through some of this a little bit quickly. Sorry, assumptions. This is too bad because this is the part that I said we like to be transparent about, and I'm going to actually do the opposite of that, which is like flip through these slides really fast because I'm running out of time. So we did a bunch of that, and here's what we get in the end. Okay, so we said you bring all this money into the state, you're going to get about 30,000 more jobs per year. 2/3 of those are in the healthcare sector, and 1/3 of them are, 1/3 of those are in the healthcare sector, and 2/3 of them are outside the healthcare sector. We get a big increase in personal income in the state. That's how much money people are taking home. And then when people are taking home more money and spending more money, you get an increase in state tax revenue. So it's this bottom line, the increase in state tax revenue, that I'm going to add to those things I had earlier. So it's nice that people are taking home more money. It's nice that people have more jobs. But what I really care about is what's coming back to the state for purposes of this analysis. And so I'm going to take this bottom line, literally the bottom line of this table, and I'm going to add it to those other rows I showed you. And I'm going to see what happens. I'm going to skip that. OK. And this is what I get. Oh, sorry, whoops. These 3 rows you've already seen. Okay, so this top row is what it costs the state, what the state has to actually pay for this new Medicaid program. This is what the state saves in its existing budget. This is what the state gets in provider tax revenue, and this is the general tax revenue increase coming from the macroeconomic thing. And when we add these 3 together, because these are all the pluses for the state economy, and then we subtract this one, which is what the state has to pay, we find large positive numbers in every year. So if you want to think about it graphically, I really like this figure. What this shows is the red line is what the state has to pay in each year for the Medicaid expansion. The light gray bar is what the state is saving from reductions in other health care programs. That's like the cuts to the state mental health budget. The medium gray is the increase in provider tax revenue, and then the very dark gray is the increase in general tax revenue. So you can see that once you add in that increase in general tax revenue, you are literally in the black with the program, even once the state has to pay 10%. So that's our bottom line. And then there's a bunch of other stuff we worried about, but Okay, so ultimately we find that the program does in fact pay for itself from the state's perspective. And the increased economic activity from these macroeconomic spillovers is about a third of that. Okay, it increases the positive benefits by about a third. We're in the black even without it, but it's kind of borderline in that last year. But once you add those final set of macroeconomic benefits, then it's a clear fiscal win for the state from people in our House Fiscal Agency. So we needed to get reliable estimates of how much the state would save associated with this. One other important thing to keep in mind is that while our result shows that it's a net positive for Michigan, this is going to be different in every state, right? It depends how much your state is already spending on healthcare. It also depends, very importantly, on what your state's tax system is. So for example, Texas and Florida, the two biggest states that haven't yet expanded Medicaid, they both have no income tax. So our calculation suggests that in Michigan, we ended up getting back 4 cents on every dollar, 4 cents as state tax revenue. Maybe they don't get that much. So all of the pieces of it are very specific to what's going on in the state. And it depends on knowing both about the state budget and the state tax system. And I can stop there and take questions. Yeah, right there.
This is very much off the subject, but is anyone looking to see if in fact the healthcare providers maybe are charging too much? Is there any sort of analytical work going that maybe that's where costs can be cut?
Okay, great question. So in the Medicaid program, the state tells them what they're getting paid. So they don't get to set their prices. And then I think and in the Medicare program also, the federal government tells them what they're getting paid. In the private market, I think there is consensus agreement that yes, they are charging too much. But for this program specifically, they have addressed that. Yeah, right there.
I have two hopefully short questions. First one is, have you, in your spillover effects, did you account for like work productivity now that you have insurance and less work?
Yeah, so we thought about that, but we didn't incorporate anything because you can make an argument either way. So you can say people are more likely to work because they're healthier, or they're more productive because they're healthier, or you can say now people get a benefit that they didn't get before, they have less incentive to work. The best estimates in the literature suggest that there is no effect. Yeah, those two things may be going on, but on balance they're canceling each other out. So we didn't include that.
One more question. So I know the staff and you just ended, but have you been able to compare now that you're paying, like your numbers that you calculated, are those sort of matching up to what is actually happening?
It's a great question. Certainly the state has seen the cuts in mental health that we would have expected, and the enrollment numbers are on target. It's very hard to say what would have happened to the budget in the absence of the program, though, so no one has tried to do an actual reconciliation. Yeah.
It might be worth mentioning that our ballot initiative actually has a funding mechanism in it, and so it holds a really small increase in the non-food sales tax, about 3 cents on every $20. The ballot initiative would be funded within itself. We don't have to go to the legislature and ask them to include it into their budget. So that's a really important piece of our initiative.
That's smart. Yeah, in the back there.
So this is really great work, and obviously in Michigan it works. I'm wondering about the error in measurement estimates of all of these different components. And did you do any sort of sensitivity analysis, and which part has the most potential error?
Yeah, so we did a lot of sensitivity analysis around the different assumptions. And it turned out not to matter that much. And the reason it doesn't matter is because most of the assumptions simply determine whether it took me a long time to understand this. The way to think about it is that the truck, let's go back to the truck full of money. Most of the assumptions just determine whether when the truck gets to Lansing, it drops the money in healthcare or not in healthcare, but it comes into the state. And so the sensitivity is around issues like spending on healthcare is more likely to stay in the state than to seep out of the state because healthcare, except for drugs, is mostly local. But those effects are relatively small. So there's not actually a ton of responsiveness to other types of assumptions because of the truck with the money, essentially. Yeah, and then question over there.
I have 3 questions. I think they're kind of quick. The first is, did your algorithm include things like people who go to an emergency department when they're really sick instead of going to a clinic visit, which is probably take a 0 off the end when the illness is just starting? Or another question like that is, they declare bankruptcy because their medical bills are so big and they can't afford to pay for them. The second question is, we have some providers in Utah that don't want to see Medicaid patients because they're too sick, they're too non-compliant. I mean, they have all these stories in their head. They don't make enough money. So how do providers feel in other states about taking Medicaid patients? And then the third question is, what if your legislature isn't using economic reasons for their decision-making, and it's all about, we don't want federal money in our state?
Yeah. Okay. Great questions, and I'm going to answer them really quickly because I know you all have other places to be. So first, does this reduce things like emergency department use? Great question. There are a bunch of studies that have looked following the Affordable Care Act at whether Medicaid expansion has reduced the use of emergency departments, and the studies find different things, but mostly they seem to suggest that that's not a big effect because people have better access to primary care, but they also have better access to the emergency room when they have insurance. So there's not a huge effect there. In terms of patient access to providers, this is an important argument against Medicaid expansion in the minds of some governors, that why would I put more people into a broken system and they're not going to be able to see doctors anyway? We were very fortunate in Michigan to have a survey conducted of our primary care providers. This survey was done by some colleagues of mine, asking them about whether they were at capacity and whether they would be willing to take more Medicaid patients. And a key piece of persuading our governor to support the expansion was this survey that showed that the great majority of primary care providers said they would see more, they had capacity to take more Medicaid patients. And in fact, follow-up surveys since the expansion have showed that there aren't a lot of access. I mean, there are access problems for Medicaid patients. I'm not suggesting all providers see them, but there was capacity to see, for providers to see more of them, and that has been the case. And third question about politics, that's a big piece of what's happening here, right? But I guess I think of the point of these economic estimates is to not let people hide their political arguments behind economic ones, right? So if they want to have an economic argument, let's have that argument, right? But you're not going to pretend that it's about economics if it's really about politics. That's my goal with estimates like this.